This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello and welcome back to the Neurosurgery Hub podcast. I'm Dr. Aris, Senior Attending Neurosurgeon.
And I'm Dr. Alara, Research Fellow. Today we're looking at a fascinating new study from the 2026 issue of World Neurosurgery titled Individualized Surgical Management of Brainstem Cavernous Malformations, a single-center experience with 50 cases and favorable long-term outcomes.
This is a topic that always sparks a lot of debate in our morbidity and mortality conferences. Brainstem Cavernous Malformations, or BSCMs, are a completely different beast compared to their supratentorial counterparts. The stakes are just so much higher.
Exactly. The paper highlights right away that BSCMs are associated with significantly higher morbidity and mortality than cavernous malformations in other locations. Because of the dense packing of nuclei and fiber tracts in the brainstem, even a small hemorrhage or a millimeter of deviation during surgery can be catastrophic.
And that's why this study's focus on individualized surgical management is so critical. They looked at 50 cases, which is a substantial series for such a specific and high-risk pathology, to evaluate clinical manifestations, decision-making, and long-term outcomes. Alara, what stood out to you regarding their surgical decision-making?
The authors emphasize that the decision to operate isn't a one-size-fits-all protocol. It's a trifecta of lesion location, surgical timing, and the use of intraoperative monitoring. They really dive into how the specific location within the brainstem, be it the midbrain, pons, or medulla, dictates the entire surgical trajectory and the choice of safe entry zones.
That's a key point for our residents listening. You don't just go for the shortest path. You go for the path that minimizes disruption to critical architecture. The paper mentions evaluating the clinical manifestations as well. In these 50 cases, the presentation often dictates the urgency, doesn't it?
It does. The study suggests that surgical timing is a major factor in the postoperative outcome. While we often wait for the subacute phase to allow the hematoma to liquefy and create a surgical plane, this individualized approach looks at the patient's neurological trajectory. If they are progressively deteriorating due to the mass effect of the hemorrhage, the timing has to be adjusted.
Let's talk about the operative techniques mentioned. For a series of 50 cases with favorable long-term outcomes, they must have been very disciplined with their intraoperative monitoring.
Absolutely. The authors argue that intraoperative monitoring is not optional for BSCMs. They used it to define the value of real-time feedback during the resection. By monitoring somatosensory evoked potentials, motor evoked potentials, and even brainstem auditory evoked responses depending on the level, they could navigate those precarious corridors with a much higher safety margin.
It's also about the individualized approach to the approach itself, whether they're using a suboccipital televelar approach for a pontomesencephalic lesion or a far lateral approach for something in the medulla. The paper really hammers home that the lesion's proximity to the ependymal or peel surface is the golden rule for selection.
And that brings us to the results. Achieving favorable long-term outcomes in a cohort of 50 brainstem patients is impressive. Most of these patients had reached a stable or improved functional state at their long-term follow-up.
It's a testament to the fact that while BSCMs are technically challenging and carry high risks, a systematic, individualized strategy can mitigate those risks. We shouldn't be as hands-off as we were 30 years ago, but we also can't be cavalier.
Right. To summarize for our listeners, the study advocates for a tailored surgical plan. You look at the specific anatomy of the 50 cases, you wait for the optimal surgical timing unless deterioration forces your hand, and you never, ever operate without a full suite of intraoperative monitoring.
It's about being a thinking surgeon. Don't just look at the MRI. Look at the patient's symptoms and the specific nuclear anatomy you're navigating. For our residents, this paper is a great roadmap for understanding the nuances of the brainstem.
Definitely. It's a reminder that in neurosurgery, the most technically challenging cases often require the most thoughtful, individualized operation.
Well, that's all the time we have for today's deep dive into World Neurosurgery. I'm Dr. Aris.
And I'm Dr. Alara. We'll see you next time on the Neurosurgery Hub podcast.